Hello and good morning. My name is Robert Morgan and I'm a nurse practitioner from Kingwood, Texas. I'm here to speak to you today about the complications of hypothyroidism. Hopefully we're going to be bringing some new information and new thoughts to the treatment of hypothyroidism. Okay, so you're going to say, what the hell was that about? But the point I want to make is that what we learn in school is a base, and it is up to us to get out, do further education, and really start to try to learn the intricacies of our practice. The first question I have for you is probably the most important. Why is it that patients actually go to the doctor? Or better yet, why do they go to their nurse practitioner? Symptoms. The most important thing you can remember is they all come to us because of symptoms. All right, we all seek medical attention when we're feeling bad, whether it's a headache or stomach ache or cough or cold, it doesn't matter. Well, what about just getting older? The problem with medical schools is they have an emphasis on disease processes. There's actually no emphasis given to the treatment of physiologic aging and the inevitable decline in your hormone and thyroid function. Today I want to talk about the definition of hypothyroid and the signs and symptoms associated with declining thyroid levels. And we need to identify at least 3 complications of untreated hypothyroidism. And I think you may be surprised at some of the things that a low thyroid level will cause. One of the first things we did was looking at quality of life. And in 2017, did a study in the clinic, and we asked patients to rate their quality of life before we started them on thyroid. A little bit small here, but if you can look at this, 192 patients were surveyed, and they rated their quality of life as averaging 4.3. Well, on a scale of 1 to 10, that's a pretty low score. 4.3 is not a really good quality of life. So then, once we got them on thyroid, we asked them again to rate their quality of life and how it had changed. And you can see here, the average score on thyroid was 8.7. Significant difference. So 3 months out, we changed their life from 4.3 to 8.7. Sir William Osler, who's known as the father of modern day medicine, actually said this. He said, "A good physician treats the disease. The great physician treats the patient who has a disease." Okay, well, let's strike that word physician, because of course, most of us are nurse practitioners, and You know, maybe clinician would be a better term that we could use. So what do you do when you do a study and you want to see if it's valid, reliable? You repeat it, right? And that's exactly what we did. We repeated the study in 2018, the following year. This was a new set of patients. There are 74 patients in this particular study, and we asked them to rate their quality of life before and after taking thyroid. And the average rating on a scale of 0 to 10, remember the other one was 1 to 10, but 0 to 10 with 10 being the best, was 3.7 before getting on thyroid. 3.7, can you imagine how poorly these patients feel? So once we got them on thyroid, you can imagine that their quality of life went up. But I asked them also, how many of you have actually been to a physician or a nurse practitioner and were told that your numbers were fine, yet you have all these symptoms, but it's not your thyroid? And you can see that 70%, 52 out of 74, 70% actually said that they had already been somewhere else and they were told that it wasn't their thyroid that was a problem. These are just some comments that were, left on the surveys themselves. And it shows, to the point that whenever you take care of something so simple, it totally can change someone's life. Absolutely. And from a business standpoint, if you're not making your patients feel better, then why are they going to come to you? Yes, I feel much better, have significantly more energy, feeling much better. Another one said, I've been on thyroid many years before coming to Kingwood Health and Wellness. I have Hashimoto's. I'm in my 30s. Now I'm 66. Anyway, it goes on. But feeling 100% better? Come on. My quality of life has drastically improved. I have so much more energy and can do so much more. I feel fantastic. We can do this for our patients. Life changer. Feel 1 million times better with thyroid. Fatigue was a big problem before. Energy throughout the day, much better. Like I say, we can make a huge, huge difference in our patients' lives if we choose to. All right, so let's get to the basics. Skipping through here. The basics of thyroid. The thyroid takes iodine, which is found in our food, converts it into the thyroid hormones T4 and T3. T4 and T3 are then released into the bloodstream, transported throughout the body, where they control metabolism, which is a conversion of oxygen and calories to energy, as we all know. So what exactly is T4? To put it simply, T4 is a thyroid molecule with 4 iodine. Now, T4 is considered a prohormone by many, and they say that it doesn't actually have a receptor site. I don't believe that, but T4 is converted into T3. So, one of the iodines is taken off, and then it is actually going to be working directly onto, the receptor sites. Now, T4 and T3 are actually the thyroid hormones. But in medical school and in nursing school, we're taught to test for something else. We're actually taught to test for the TSH. The TSH is thyroid stimulating hormone, and is considered the gold standard, but it's the brain telling the thyroid to work harder or not. And this becomes very important in your practice, okay? The TSH is not a thyroid hormone. It is a pituitary hormone. And in physiologic aging, the TSH is not going to respond to a slow decline in thyroid function. It will respond to, let's say, radiation poisoning or, something that insults the thyroid. But it does not correlate with hypothyroidism. I want to repeat this. The TSH does not correlate with hypothyroidism. Now, this is another lecture. In fact, this is one of 3 parts, and it is a basic. I have a whole lot more, go into a lot more depth, but you got to realize what we're looking at and what you're testing. Thyroid antibodies. There are a lot of different problems that can occur with thyroid. We look at TPO antibodies, thyroid peroxidase antibody. We look at checking for Hashimoto's. There are several different ways. If we're looking for Graves' disease or hyperthyroidism, remember Graves' disease is an autoimmune disorder. So if you're putting somebody on thyroid and their TSH goes down and your friendly neighborhood endocrinologist says that they're hyperthyroid, he's absolutely incorrect. Hyperthyroid is an autoimmune disorder. This is just a slide I put in to give you some differences in what's being tested to refer back to. Now, this here is actually a sheet that I developed to visualize, be able to show patients where their symptoms are, where their levels are, and to kind of follow things along. And this is based on a treatment model that I developed back in 2002 to get the levels up to the upper third or upper half of the range where symptoms disappear. This is actually my copy right here. So we just do an overview of the patients. And remember that as nurse practitioners, we emphasize patient teaching. And so, you got to remember the more that you can teach a patient, the better the patient's going to comply, the better they're going to feel. And it protects you because you don't want them going to their OB or their family doctor and having what you're, doing questioned. The worst thing that could probably ever happen is, they say, why are you on this thyroid? And the patient says, I don't know. Or, the family doctor or clinician tries to say, well, your TSH is low or, what have you. And you want your patient to be able to defend and understand why they're on thyroid. So what are some of the causes of low thyroid? Okay, well, there are a lot of causes actually. Low iodine traditionally, whether it's low iodine in the soil, in the water, but low iodine has always been an issue. Some of the other things that people don't think about would be like the advent of 4G and 5G technology. Low levels of radiation have been shown, to be potentially dangerous, even in the low levels that we get in our cell phone. And everybody has a cell phone, right? Where do we hold it? We hold it right here. Where's our thyroid? Right here. So can this make a difference? Well, I don't know. Let's just see. If you look here, this is actually a study that was done on medical students, okay? It was in 2017. Now, it was a small sample size, only 83. undergraduate students, but 53% of them spent half an hour talking on the cell phone daily. 29% spent an hour and a half, and 11% spent over 3.5 hours. Now then, I want you to look at these images that I'm putting up. These images actually show 15 minutes on the phone. 15 minutes. On the left is before, on the right is after. If you can see red versus green, you see that, you see all of that lit up. That's a 15-minute call, and it totally lit up, you know, their thyroid. Well, low iodine causes a problem, but high iodine can also cause a problem. High iodine intake is associated with autoimmune thyroid disease. A sudden increase in high iodine can cause problems just like radiation. The thyroid is the only gland in the body that can actually uptake iodine. And that's why we worry about radiation so much. How do we treat Graves' disease? How do we treat thyroid cancer? With radioactive iodine. So how important is iodine? I want you to think for a minute about your Morton salt. Have you ever wondered why salt is iodized? You probably haven't, but you know, they added iodine into salt back in 1924 because the majority of people, like, let's say like in the goiter belt, in Michigan and, you know, other regions up in that area, people had a lot of goiter. They were having all kind of significant problems with focus, concentration, energy. They actually had cretinism, neurocognitive impairment, all because of low iodine. So they put iodine into salt. Like I say, that was in 1924. Now, if you look at maps and look at the iodine deficiency in water, it correlates actually with ADD and ADHD. So I want you to kind of tuck that back in your mind for a minute. Excuse me. But this map here will show you where up to 70% of children had goiter. Okay. Now this is iodine deficiency in water. Let's look at iodine deficiency in the soil. Okay, so you can see the states with iodine deficiency in the soil. All right, I want to go back. You see the water, you see the soil. Now I want to show you another map. This is a percentage of children with ADHD. And if you look, you will actually see these areas highlighted where there's iodine deficiency. So isn't it funny that ADHD and low thyroid are actually potentially connected? Now then, I already gave you a preview of the next slide, but what does iodine deficiency or hypothyroidism look like? It can be pretty drastic, right? But look at this guy. Seems like maybe we would recognize a few things there. What about this lady here? Can you see the goiter right here? Maybe here. A little bit of cretinism. More recently, look at this. Here. Now, of course, these are before and afters. You might actually recognize this girl. Look at this. It's funny, a lot of people thought that Sophia um, had facelifts and all these other things when actually she developed thyroid cancer. Then she had a thyroidectomy, was put on thyroid, and eventually when they got her thyroid under control, of course, the beauty came back out and she became a superstar. Now everybody knows the next woman. We got the skinny Oprah, the fat Oprah, the skinny Oprah, the fat Oprah. Her doctors just could not get her thyroid regulated for a little while. Someone else for you young ones out there, Denise Richards. Now, if you look at Denise, she was actually on TV, and it was pointed out that by her fans that, hey, we think you have a thyroid problem. So she went and had it checked out, and of course she did, and they got her on thyroid, and she looks fabulous. When I graduated nursing school, look at this. Wow. Do you notice right here? Thyroid makes a huge, huge difference. Now, where's it at? Why are all these people have this? It's location, location, location. Remember that the thyroid, sits right around the larynx, right? The trachea, so it can affect your swallowing, it can affect your speech. It makes us look like we have this big fat neck, which some people just have a big fat neck. But whenever you have an enlarged thyroid because it's working harder, that's what you're going to see. So start looking at your patients before you even put hands on them and palpate that thyroid, okay? Here's one thing that really cracks me up. If you look at the thyroid, even the back view, the front view, what's it made out of? Nodules. It's nodular. So when someone tells me their doctor told them they have nodules, my first question is, did they biopsy? Now, why would they biopsy? Because it's a procedure. We make money. Oh, yeah, you get the ultrasound, you biopsy, you get to charge them. And it's all in the name of making sure you don't have cancer. So who's going to question it? Now, this is the HPA axis in more detail. The most important concept is it's a negative feedback system. It's semi-complicated, but I break it down into a simpler system, easy to understand, easy to explain to the patients, and it makes it easier for them to visualize, in my opinion. I've been using this drawing or cartoon since 2003. The HPA axis, like I say, is complicated. Most important thing to remember about it, though, is it's a negative feedback system. So whenever you put thyroid into the tank, what's going to happen? The levels go up, the float goes up, the TSH goes down, and the T4 that's being produced by the thyroid goes down, which can affect the T3. So is it just about looks? All these big thyroids and what have you, or is there more to it? Let's look at the actual, some of the actual issues related to hypothyroidism. We all know what this is: fat, cholesterol. We get these big things, we show our patients, and a lot of people want to put them on statin drugs. But guess what? Low thyroid is associated with high cholesterol, triglycerides, metabolic syndrome. All right. It's also associated with hyperprolactemia. Now, a lot of people don't think about hyperprolactemia in men, but they should. We worry about prolactin. We think about galactorrhea, amenorrhea in women. But look, women who have hypothyroidism 94%, right? Amenorrhea, 85% galactorrhea. Look at men, 78% with hyperprolactemia have impotence. Do you not think that's a big problem? Of course, we can give them Viagra and Cialis and L-arginine and do all kind of other things, but maybe it's just a low thyroid level contributing. Men can have galactorrhea, headaches, hypopituitarism, and the visual field defects actually occur in men and women. You'll see this when you put them on thyroid and they have to have their glasses prescription changed. Rheumatoid arthritis, bone and joint pain, you'll see that. Now, I'm a member of WorldLink Medical, so I do a lot of research. They use Medline, Sentinel, a great source that anybody can join. And if you like research, you want to really look at some actual studies, this is a great way to do it, unless you're in university still and you have access to the library. This study looked at thyroid function and score system and found that the current scoring systems do not accurately diagnose hypothyroidism in the elderly, and the symptoms are more predictive. Symptoms, which is why they come to us in the first place. In this study here, you can see women in the subclinical hypothyroid group showed significantly higher cholesterol and triglycerides than those in the normal thyroid group. The prevalence of metabolic syndrome in the normal thyroid group was 26% and 18%, but in the subclinical hypothyroid group, much higher, 39% and 29%. Journal of Internal Medicine showed that the prevalence of hyperprolactemia and subclinical hypothyroidism is notable. Meta-analysis presented in Endocrine suggested that rheumatoid arthritis was more prevalent in patients with thyroid autoimmunity. This study here was in Elsevier, and they concluded that subclinical hypothyroidism leads to an intermediary lipid profile between euthyroid individuals, and that, you know, is found to manifest in hypothyroidism, and a significant lipid profile improvement occurred when thyroid replacement was given. Another big problem with hypothyroidism is cardiovascular. Arterial stiffness occurs, which increases diastolic blood pressure. This is a result of low thyroid levels, in particular T3. According to JCEM, hypothyroidism is associated with an increased cardiovascular risk and increased central aortic pressures and central arterial stiffness, which actually improved in reverse when given adequate thyroid replacement. In this study published in the Journal of Vascular Disease Management, they stated that patients with low thyroid levels were found to be at higher risk of hypertension, in particular diastolic hypertension. They also found a direct correlation between low thyroid levels and elevated cholesterol. Here's JAMA. It was found that subclinical hypothyroidism is associated with an increased risk of coronary heart disease events and mortality. The Annals of Thoracic Surgery. You notice these magazines are well known, they're well respected. But anyway, in the Annals of Thoracic Surgery, patients with subclinical hypothyroidism had a higher incidence of atrial fib, than those with normal thyroid levels. So think about that for a minute. When patients are overweight, they have obstructive sleep apnea, they have a lot of times atrial fib. Maybe it's related to a low thyroid level. Oh, but we don't give thyroid for weight loss. But if you have low thyroid, you gain weight. I'm just saying. JCEM study right here showed women who are positive for TPO antibodies or Hashimoto's develop impaired thyroid function. Duh, Hashimoto's equals hypothyroidism, which is associated with an increased risk of miscarriage and premature deliveries. Treatment with T4, levothyroxine, reduced the chances of miscarriage and premature births. Circulation. JCM study showed women who are positive for TPO, let's say, were associated with increased risk of miscarriage and premature deliveries. But now in the Journal of Circulation, which is, you know, that cardiologist journal, they reported that in hypothyroidism, arterial compliance was reduced, leading to an increase in SVR. Okay, so you have a rise in diastolic blood pressure, low cardiac output, and lower pulse pressure. Where do you want your levels to be? We want to get those thyroid levels up and prevent these problems. The cardiologist also noticed that given thyroid decreased the systemic vascular resistance and afterload, which is a good thing, and ultimately improved cardiac output. They also characterized that low thyroid resulted in hypercholesterolemia, an increase in LDL, and apolipoprotein B. Therefore, hypothyroidism is associated with an increased cardiovascular risk. I'm sorry, these are cardiologists. This is a Journal of Circulation. They continued on to say that hypothyroid patients have other atherosclerotic risk factors and an apparent increased risk of strokes, prolonged QT interval, and that treatment with full replacement levothyroxine or T4 can and should be initiated at the onset. And approximately 30% of congestive heart failure patients have a low T3. The Journal of Cardiology featured this study, which compared patients who have atrial fib who are on levothyroxine to patients with atrial fib who are not on levothyroxine. They found that hypothyroidism is associated with a decreased cardiac function. They also concluded that there was no significant increase in cardiovascular risk, which is always an argument when you have patients on thyroid. So they actually found that T3 improves cardiac function. Comparison of mortality and non-fatal cardiovascular events in adults with atrial fib with versus without levothyroxine treatment. 2017 Journal of Cardiology. A significant association between levothyroxine treatment and lower mortality was found among women. This was a good study involving 12,283 patients. They concluded that there was a significant improvement in mortality in patients who were treated with levothyroxine. They also concluded that thyroid treatment was not, I want to say that again, they also concluded that thyroid treatment was not associated with the risk of MI, stroke, or congestive heart failure. In summary, T4 decreased the risk of mortality in patients with atrial fib. But what do cardiologists know about the heart or atrial fib? Because every cardiologist that I've ever talked to, if a patient was in atrial fib, they would try to blame it on the thyroid if the patient was on thyroid. Current medical issues, 2018 reported that subclinical hypothyroidism is associated with elevated cholesterol and measures of cardiovascular disease. Also, that hypothyroidism, or high TSH, are associated with an increased BMI and waist circumference. They also reported an increase in leptin levels, infertility, spontaneous abortions, gestational hypertension, and preeclampsia, all to be associated with low thyroid, subclinical hypothyroidism. And they recommended that thyroid be given to suppress the TSH. In psychology today, depression, anxiety, and poor energy are very common symptoms of low thyroid, as well as low testosterone therapy. It may take months to be effective in minimizing or improving symptoms. But low thyroid is one of the most common causes of depression, anxiety, and low energy, according to Psychology Today. Long-term augmentation with T3 in refractory major depression. The addition of T3 is one of the most widely studied augmentation strategies for refractory depression. And they concluded that T3 may successfully be employed as a long-term treatment of major depression. The Hunt study was, this was published in Archives Internal Medicine, looked at the risk of fatal coronary heart disease and found that even as a relatively low thyroid level may increase the risk of fatal coronary heart disease. So like I say, where do you want your levels to be? Low thyroid levels are an increased risk of mortality after an acute MI. Another study published in 2018 shows low thyroid levels are a strong predictor of poor cardiovascular outcome. And I have all these in the references. So with all the risk associated with low thyroid levels, I can't stress enough, where do you want your levels to be? Subclinical hypothyroidism is associated with cardiovascular risk, metabolic syndrome, depression, anxiety, poor energy, right? Hyperprolactemia, rheumatoid arthritis, increased risk of miscarriages and premature births. I have letters to the editors. These are endocrinologists who basically said it appears that the laboratory medicine has overcome clinical medicine in diagnosis and treatment. Whatever happened to the patient? All right. So what's this endocrinologist saying? Hey, we're no longer looking at the patient. We're not looking at symptoms. Everybody's wanting to look at these lab tests and numbers, and we're trying to get these numbers right. But what about the patient? And multiple endocrinologists actually wrote into, a response to this article that, was saying, look at the numbers. Well, of course, the endocrinologists that are working in the clinics are saying, hey, what about the patients? we need to look at the patients. You know, we think about the standards of care, and the standards of care are what we're judged by. And everybody's looking at the TSH, right? Well, I want to remind you of the standard of care and how it changes, okay? Because looking at your, you know, T4 and T3 levels and listening to your patients make a whole lot more sense than trying to, you know, look at the TSH, which has never been proven to correlate with hypothyroid. So I just want to leave you with this. This was a standard of care for almost 3 decades. If a woman spoke out, right? If she was unruly and didn't listen to her husband, this is what happened. The nice little ice pick through the brain, transorbital lobotomy, voila. Now, do we want that standard of care? Because that was the standard of care up and through the 70s. Anyway, thank you for your time. Thank you for your attention. wellnessmp@gmail.com. I included my phone number. I do have a multitude of thyroid presentations, and we will see you soon. Thank you. If I can be of any help, let me know. Here are some of the references that will be included. Case study, I just left that out. Too complicated right now.